Hi, everybody. This is Derek Srouji. Today, I will be doing my journal club over the Victoria trial, which looked at the novel cyclic guanylase medical therapy of vericiguat in patients with heart failure with reduced ejection fraction. To touch off, speaking on the burden of heart failure in today's society and hospitalizations, you'll notice that there are multiple clinical trials over the last several years and ongoing throughout this year that are looking at novel therapies to help reduce the burden of heart failure, particularly patients with reduced ejection fraction. We've seen clinical trials such as Paradigm, DAPA-HF, Emperor, Galactic HF this year, and then this trial, Victoria, that is all looking at novel therapy to try and help decrease hospitalizations for these patients with systolic heart failure, reduced ejection fraction. I have some metrics here. As you can see that the estimated total cost of hospitalizations with primary heart failure is up to be 11 billion in most recent accounting in 2019, which Medicare absorbs the majority of these costs. In 2019, heart failure contributed to about 4 million emergency room visits and 3.4 million hospitalizations with approximately 230,000 deaths. It was estimated that approximately 8 million people in the US will have heart failure in the year 2030. Half of these patients will have systolic heart failure or reduced ejection fraction. So as you can see, just looking at these metrics, you get a glimpse of the burden that our patient demographics in the hospital are having heart failure, systolic heart failure. So it is of clinical interest to find novel therapy to try and reduce the burden as we do, or as this trial tries to investigate with vericiguat. Next, kind of touching on the pathophysiology of vericiguat, so you kind of get a better understanding before we move into the trial. In heart failure, or just in general, in normal physiology, there is a very complex pathway, endothelial driven pathway of nitric oxide with soluble guanylate cyclase. That nitric oxide typically has a large effect, a vasoprotective effect, an endothelial lining protective effect, a platelet aggregation inhibition effect that all contributes to maintaining a stable cardiovascular endothelial lining. One of the two of the hallmarks of heart failure in general is endothelial dysfunction and reactive oxygen species. Both of these contribute to a decrease in nitric oxide, which then decreases obviously to the downward or down pathway effects of soluble guanylate cyclase and CGMP activity. So it was a pathway that was heavily studied to see if there can be improvements in this pathologic process in heart failure. That was how kind of the origins of vericiguat, that was a novel soluble guanylate cyclase activator that then promoted CGMP activity and promoted things such as decreased progressive myocardial stiffening, decrease in myocardial thickening, decrease in ventricular remodeling, also had vasculature protection such as decreased arterial constriction and decreased vascular stiffness. And that was the origins of the creation of vericiguat. And so now with this establishment of that drug, researchers tried to look to see if this would have effect in patients with systolic heart failure or reduced ejection fraction. So now that we've touched on kind of the pathophys of that, it brings us to our clinical trial of Victoria that asks the clinical question of what is the safety and efficacy of vericiguat, a novel oral soluble guanylate cyclase stimulator in patients with heart failure with reduced ejection fraction. The primary outcomes of this study were twofold: cardiovascular death and first heart failure hospitalization. You'll see as you look at cross-trial analyses of recent times, such as the trials that I mentioned, DAPA-HF, Paradigm, Galactic HF, among many others, have similar primary outcomes or the same primary outcomes that allow us to do more cross-trial analysis in terms of our hazard ratio, our relative risk reductions. So that allows us some benefit in trying to compare these novel therapies and what kind of effect they're having on our patient demographics. The study design overall for this trial, it was a randomized placebo-controlled parallel group. It was multi-centered. It had a good amount of enrolled patients. It had a strong power. It was 5,050 patients that were enrolled. These were separated into two branches, the vericiguat arm and then the placebo arm, which were evenly distributed. Initially, 6,857 patients were enrolled prior to screening, and that's how they were screened down to approximately 5,000 patients when we incorporated our inclusion and exclusion criteria. They were screened across 616 sites across 42 countries. The interval for this study time was studied from approximately September 2016 to December 2018, so this is a relatively current study. And it was an intention to treat analysis. The inclusion criteria and the exclusion criteria for these patients, the inclusion criteria consisted of patients with chronic heart failure originating from the NYHA class 2 to 4. And these were patients on goal-directed medical therapy prior to this study. Injection fraction was less than 45% in these patients, and that was assessed within 12 months prior to enrollment. In terms of BNP levels, they had to have at least a BNP level of equal to or greater than 300, and these were for patients that were found to be in sinus rhythm. If they were found to be in atrial fibrillation, they had to have at least a BNP of 500. Another interesting inclusion criteria that this trial included is separated its patients into 3 cohorts. Patients that were either hospitalized within 3 months, hospitalized within 3 to 6 months prior to enrollment, or patients that didn't require hospitalization but required rescue IV diuretic therapy in the outpatient basis. And so this gives us a clue that in terms of these inclusion criteria patients that were being enrolled, they were quite high risk. And we'll talk a little later about the patient demographic and how high risk these patients were compared to other trials that looked at novel therapy. But as you can see, these patients had frequent recent decompensations that were being enrolled into this trial. So they were quite high risk. In terms of exclusion criteria, patients that had systolic blood pressure of less than 100 were excluded. Patients that had concurrent use of long-acting nitrates or phosphodiesterase inhibitors were excluded. Patients that had concurrent use of IV inotropes or were requiring left ventricular assist devices were excluded. And then patients that were awaiting heart failure transplantation were excluded from this trial. Patients that had CKD, that had GFRs less than 15, had lung disease that were requiring supplemental oxygen, or had hepatic insufficiency were also excluded from this trial. In terms of baseline characteristics for this trial, they were pretty evenly distributed amongst the 2 arms, our vericiguat arm and our placebo arm. The average age was about 67 years old. Only 24% of females made up this study. A very small representation of Blacks, only comprising about 5%, where the large majority were whites, comprising 64% in terms of characteristics. Again, as you see the distribution of our NYHA class, you can see another touching on the high-risk nature of these patients being enrolled. Essentially, 40% of these patients were classified as NYHA class 3. So these are pretty advanced heart failure patients that are being enrolled into this study. The average ejection fraction was 29%, and then the average BNP for these patients was about 2,800. So again, I mean, that's quite elevated, and you'll see as compared to some other cross-trial analysis that, again, just to kind of reiterate the high-risk nature of these patients being enrolled. In terms of their goal-directed medical therapy prior to this study, 90% of patients were on at least dual therapy that included a beta blocker or ACE inhibitor or ARB. 60% were on triple therapy, included beta blocker, ACE or ARB, or mineralocorticoid receptor antagonists. Only about 15%, interestingly enough, of these patients were on Entresto therapy. And that is peculiar, as Entresto has been pretty well established as guideline-directed medical therapy for these heart failure patients. So only 15%, and then also none of these patients were on SGLT2 therapy as well. 32% of these patients had ICD placement or BiV implantation. To kind of show a distribution of our patients that we went on, as I mentioned, they were distributed into two arms, our Versaguat arm and our placebo-driven arm. These patients, as you can see, throughout the trial, 610 were discontinued out of the Versaguat arm, and 565 were excluded from the placebo arm, and you can see for the actual distribution of reasons for why they were discontinued. These patients were initiated on 2.5 milligrams daily of their respective therapy, either Versaguat or the placebo, and they were followed on the outpatient basis at intervals of weeks 2 and then weeks 4, and then at that point were followed every 4 months until the end of the trial. These patients were monitored each time they were seen in the clinic setting, and were up titrated appropriately until they maximize or optimize their dosing of 10 milligrams, in addition to their pre-existing goal-directed medical therapy, whatever they were on prior to that. They were monitored for adverse effects at each visit, and that kind of drove their up titration and optimization of their medical therapy. The placebo arm was mirrored in this respect in terms of being initiated on 2.5 milligram dosing and then up titrated slowly to 10 milligram optimized dosing. Here we look at our Kaplan-Meier curves that will give us a graphical distribution and analysis of the primary outcome, as you can see in the top left-hand corner of our primary outcome, which again was first heart failure, hospitalization, and cardiovascular death. As you can see, our hazard ratio was 0.9, relating to a 10% relative difference between placebo and Versaguat. That corresponded to an event reduction of 4.2 events per 100 patient years, and calculated out to a numbers needed to treat for 1 year to prevent primary outcomes of 24 patients. So as you can see, I mean, these are significant results. We'll touch on our cross-trial analysis a little later in the presentation and compare our hazard ratios to other studies that looked at novel therapy, namely Paradigm with Entresto and DAPA-HF with SGLT2 therapy. I think as you can see in the top right-hand corner, when we look at death from cardiovascular causes, the results are a little less significant in terms of a hazard ratio of 0.93. And you can see in our graphical distribution as the lines cross, meaning that there's not quite as much of a divergence between the patients that were receiving Versaguat versus placebo. As compared to our primary outcome back in the top left-hand corner, you can see that the divergence of lines corresponded pretty early on, almost about 3 months, that you were already seeing kind of a significant difference between the two studies. Our secondary outcomes in the bottom right-hand corner, death from any cause or hospitalization for heart failure, also mirrored our primary outcome in terms of a hazard ratio of 0.9 and did have a p-value of 0.02. So these were significant results. In terms of safety and tolerability of these patients, the two biggest components of adverse effects that were appreciated during the clinical trial were namely symptomatic hypotension and syncope. Symptomatic hypotension occurred at a rate of 9.1% in the Versaguat arm versus 7.9% that occurred in the placebo arm. Syncope occurred at a rate of about 4% for the Versaguat arm as compared to about 3.5% of the placebo arm. But those were the two most common and prevalent adverse effects that occurred during the clinical trial. Another event that occurred was anemia that occurred at a rate of 7.6% of Versaguat and versus 5.7% of placebo. And in the discussion portion of the trial, the researchers even mentioned that they didn't have a clear-cut reason for what the pathophysiology for why anemia was occurring, but it was something that they were appreciating in the trial. There was no renal function or electrolyte abnormality that was significantly appreciated amongst the patients in the Versaguat arm So that was a plus in terms of monitoring for this, this therapy and the safety of it looking forward. At 12 months, 10 milligrams of the target dose was achieved in about 89.2% of our Vericiguat patient population and 91 versus 91.4% of our placebo arm. I think it is worthwhile to note that as this was a event-driven study, even the researchers touched on that they accrued their event capacity at an earlier rate than they were anticipating. Almost at about 11 months did they actually have their events that they had set out and predicted upon. They mentioned that because of that, it limited potentially the long-term outlook on Vericiguat and the long-term outlook that it can have on patients, because they were not anticipating how soon that they were going to accrue all their events. And as we kind of touched on, one of the reasons that you could have seen that high event distribution in the Vericiguat arm was in part because of the high-risk nature of patients that were being enrolled into this study. As we kind of talked about, touching on our cross-trial analysis, different landmark studies that have occurred over the last several years looking at different novel therapy. I think Dr. Toman presented DAPA-HF earlier in the year that looks at dapagliflozin or SGLT2 therapy as a novel therapy for patients with heart failure with reduced ejection fraction, and then Paradigm looking at angiotensin receptor neprilysin inhibitor and Entresto therapy that have been both well supported in terms of their therapy and the effect that they have in patients with reduced ejection fraction. You can see, looking back at their trials compared to Victoria, their numbers needed to treat were both 21 respectively as compared to 24 patients in the Victoria trial. Their hazard ratios were a little more impressive. DAPA-HF had a hazard ratio of 0.74 and Paradigm of 0.8 as compared to 0.9 in our Victoria trial. Just to kind of illustrate what Vericiguat was going against in terms of establishing new goal-directed medical therapy and new novel therapies that can help in heart failure and systolic heart failure. In addition, looking at the NYHA class 3 to 4 particularly that were enrolled in these respective trials as compared to our trial in Victoria, to kind of illustrate further the high-risk nature of these patients that were being enrolled. Class 3 to 4 was about 25% in Paradigm and 32% in DAPA-HF as compared to 41% in our Victoria trial. Looking at the pro-BNPs, 1608 was the average in the Paradigm study and 1437 in the DAPA-HF as compared to 2816 in our Victoria trial. So as you can see, nearly doubled the BNP levels of the patients being enrolled, so considerably more at-risk patients. The annualized rate of primary composite outcomes occurred at a 33.6% rate of our patients being enrolled into the Vericiguat arm. And that was kind of what I mentioned, potentially by the high-risk nature of these patients being enrolled, which was nearly twice as much as the above studies. And as the authors mentioned, this can contribute as them accruing event-driven patients and patients that encountered their primary outcome earlier than they were expecting. However, the annualized reductions in absolute risk that filters out the nature of the annualized rate were similar across these trials. So, taking into all of that consideration and all of that cross-trial analysis, how do we come to a conclusion of this agent, and what do we do with it going forward? The pros: it's a once daily medication. It's easy to titrate. It was relatively well tolerated, and it did not. There was no appreciable renal dysfunction or electrolyte abnormalities, which is always beneficial in patients, obviously with poor systolic heart failure. Obviously, we're closely monitoring their electrolytes and their kidney function anytime they're coming in with congestion or decompensation. But how do we compare it with other novel therapies such as the SGLT2 or ARNI? It's my personal opinion that I don't think it was quite as beneficial. I think there was significance found, and it can be beneficial for the right patient. However, we have to ask ourselves, as we continually evaluate new novel therapy, how are we going to tell our patients to continually add medical therapy to these patients? How are we going to educate them, and how are we going to have discussions with them and say, hey, I want you to continually, every time I see you, take this new novel oral therapy that has just come out that is shown to show effectiveness. We're really going to have to parse which therapies are showing the most benefit and what our patients can afford and what can they reasonably take. The pill burden is becoming so large for these systolic heart failure patients. How are we going to decrease that, or how are we going to get the most bang for our buck with these patients? You know, if Versigua was, you know, cheap in terms of pennies, maybe we could find patients that would benefit from it, but it's not going to be cheap. I would imagine it's going to be quite expensive. So, you know, how do I tell my patient, hey, I need you taking a beta blocker, an ACE inhibitor, a mineralocorticoid receptor antagonist, Entresto, SGLT2, and now tack on Versigua or you know, other down the road novel therapies that are being included? Are you really going to get the most bang for your buck from this in terms of your costs, in terms of your pill burden? So it's really a conversation that you need to have with your patients. No doubt it's shown effectiveness, but is it showing such a significant effectiveness to kick out our ARNIs or our SGLT2 therapies? That's the conclusion of my trial, the Victoria trial. Hope you enjoyed. And that's the end of the presentation.